Okay, let's unpack this. We've got these really detailed notes here on medial epicondylitis.
Right, golfer's elbow. Much easier to say.
Exactly. Golfer's elbow. So our mission really is to dive into this, pull out all the key stuff you absolutely need for revision and, make it stick.
Sounds like a plan.
Think of this as your high-yield guide. We'll hit everything, what it is, causes, management, the whole lot, plus some memory aids.
Absolutely. It's interesting because golfer's elbow, it seems quite specific, but it can really impact daily life, can't it?
For sure. So let's get into the nuts and bolts, get that clear picture for revision. First off, the basics. What exactly is golfer's elbow?
Okay, so at its heart, golfer's elbow is basically pain and inflammation. It affects the tendons in your forearms, specifically where they attach to the medial epicondyle.
That bony bump on the inside of the elbow.
That's the one. And the crucial thing, the main takeaway, is that it's usually down to repetitive strain or, overuse of those forearm muscles.
Right. And it's funny, it's called golfer's elbow because presumably it's not just golfers getting this.
Oh, definitely not. That name is a bit misleading, yeah.
So what actually triggers it? What's the why?
Well, the real culprit is repetitive movements. We're talking forearm and wrist movements done over and over.
Okay.
This repeated stress, it causes tiny we call it microtrauma in the tendons. And eventually, if it keeps going, you get a breakdown of the actual tendon fibers. So think about a golf swing, yes, but also things like gripping tools tightly, throwing motions like baseball.
Racket sports, maybe?
Racket sports, exactly. And even using things like vibrating power tools. It all puts stress on that same inner elbow area.
So it's more the motion than the specific sport or job title. Who tends to be more at risk then?
Well, yeah, those repetitive or forceful forearm and wrist movements, that's the big one. But it's also how you do it.
Technique.
Yeah, technique matters.
Yep.
Incorrect form in sports or even just how you do things at work can really ramp up the stress and therefore the risk. Interesting.
Age plays a part too. It seems to be more common in the, say, 40 to 60 age range.
Okay.
And naturally, certain jobs or hobbies that involve those repetitive actions just make you more likely to run into it.
Right. Makes sense. Okay, so we've got the what, the why, the who. Let's go a bit deeper. What's actually happening inside the elbow joint and the tendons, the pathophysiology?
Right. This is where it gets quite interesting physiologically. So we mentioned the repetitive stress causing those micro tears.
Yeah.
Now, the main tendons involved belong to what's called the flexor pronator group.
Flexor pronator.
Yeah. And the notes specifically mention pronator tears and flexor carpi radialis. These are key muscles for flexing your wrist.
Bending it down.
Bending it down, exactly. And pronation, turning your palm downwards.
Gotcha.
So repeated stress causes tears, leading to what's called tendon degeneration. But it's not just the tears. You often get inflammation. Sometimes the body's healing response isn't quite normal. It's a bit dysfunctional.
Like it tries to fix it but makes it worse. Sort of, yeah. And you get changes in the collagen, the actual protein structure of the tendon. All that contributes to the pain and, losing some function.
Okay, wow. So if someone comes in with that inside elbow pain, could it be something else? Well, you need to think about differential diagnoses, right?
Oh, absolutely crucial. You always have to rule other things out. The classic one people think of is tennis elbow.
Which is lateral epicondylitis.
Exactly, lateral epicondylitis. But the key there is the pains on the outside of the elbow.
Oh, wait, different spot.
Right. Other possibilities could be maybe an injury to the ulnar collateral ligament, sometimes osteoarthritis in the elbow itself. And you've got to think about referred pain, too, like from nerve issues in the neck, cervical radiculopathy.
So the pain feels like it's in the elbow, but the problem's actually higher up.
Precisely. And then there are just other types of, general tendinitis or tendinopathy that can occur around the elbow joint. So lots to consider.
Definitely sounds like it. So zooming out again, how common is this? What's the epidemiology like, say, here in the UK?
Well, compared to its cousin tennis elbow, golfer's elbow is actually thought to be less common.
Oh, okay.
Yeah, maybe about 1/7 as common, according to some estimates. But those risk factors we talked about, repetitive wrist flexion, gripping those are definitely key drivers in the population.
All right.
It's still a primary cause of that medial, that inside elbow pain. And it can affect people of various ages, really depends on their activities.
Okay. So let's picture someone coming into clinic. What are they typically going to tell you? What are the clinical features we're looking for?
The main thing, the absolute hallmark, is pain and tenderness right over that medial epicondyle.
Right on the bone.
Right on that bony point inside the elbow. And the pain typically gets worse when they flex their wrist or pronate their forearm, turn the palm down.
Those specific movements.
Yes. And interestingly, some people might also get numbness or tingling, usually in the fourth and fifth fingers, the ring and little finger.
Why is that?
That suggests the ulnar nerve, which runs very close by in that area, might be getting a bit irritated or compressed. They often describe it as a kind of dull ache, maybe starting gradually, and it's definitely aggravated by using those muscles, things like gripping, lifting, even twisting a doorknob sometimes. And yeah, there's a specific test mentioned, the golfer's elbow test. Basically, you resist their attempt to pronate the forearm and flex the wrist simultaneously. If that reproduces their pain, it's a pretty strong sign.
Okay.
And if you suspect that ulnar nerve involvement, you'd also check for decreased sensation in those fingers, the tingling, maybe even some weakness in their hand grip or small hand muscles.
So a good history is key, asking about activities too.
Always. Gotta ask what might have triggered it or what makes it worse.
Okay. So history and exams sound really important. What about specific tests like imaging? Are they always needed?
Usually no. The diagnosis is mostly clinical based on the story and the examination findings. That's what the notes emphasize too.
Right.
However, you might order imaging like an X-ray or maybe an MRI in certain cases.
Like when?
Well, if you need to rule out other things like arthritis or maybe a fracture if there was trauma, or if the symptoms are really persistent, chronic, or just not getting better with the initial treatment, then imaging can sometimes help clarify things.
Okay, that makes sense. So we've identified it. How do we actually treat it? What's the management strategy?
Good news is the first approach is usually conservative, non-surgical.
Right. What does that involve?
It's a package deal, really. First, rest. Giving those tendons a break from the aggravating activity.
Easier said than done sometimes.
Tell me about it, but crucial. Then, activity modification, figuring out how to do things differently or avoiding certain tasks for a while.
Okay.
Physiotherapy is really key. Exercises to gradually strengthen the forearm muscles, improve flexibility, that sort of thing.
And pain relief.
Yeah, over-the-counter stuff like NSAIDs, non-steroidal anti-inflammatories like ibuprofen can help with pain and inflammation. Also, applying heat or ice packs can give some symptomatic relief.
Simple measures.
Simple, but effective often. And importantly, avoiding really high-force tasks and strong gripping while it's healing. Sometimes a supportive brace or strap, an orthosis, can help offload the tendon a bit during activity.
Okay. What about medication specifically?
Well, paracetamol might be a first step for pain. Topical NSAIDs, the gels or creams you rub on, are often recommended before trying oral pills, maybe fewer side effects.
Right.
Oral NSAIDs might be considered if the topicals aren't enough. Steroid injections? They're mentioned, but the guidance usually suggests caution.
Yeah.
They might give short-term relief, but potentially not great long-term outcomes, so not usually routine.
Okay, interesting.
There's also mention of topical GTN glyceryl trinitrate as a patch or cream, used for up to 6 months in some cases. Seems to work by improving blood flow, perhaps?
Less common one.
A bit less common, yeah. Now, if someone tries these things for, say, 6 weeks and there's not much improvement, then you really need to step back, reevaluate the diagnosis, make sure it is golfer's elbow, and maybe consider more intensive physiotherapy. That could involve more specific exercises, maybe manual therapy like massage, therapeutic ultrasound, or different taping techniques.
Right. And when would you send someone to a specialist?
Referral is usually suggested if the diagnosis is really unclear, if the pain is super severe or causing major functional problems, or if things just haven't improved after a good go at primary care treatment, say 6 to 12 months.
Okay. And what can specialists offer?
In secondary care, they might explore other options. Things like injections of autologous blood products, platelet-rich plasma, PRP is the well-known one, using your own blood components to try and boost healing.
Heard of that?
Hyaluronan gel injections are another possibility. Then there are more investigational treatments, maybe less common, like using bone marrow aspirate concentrate, BMAC, or autologous tenocyte injection, ATI, basically using your own cells.
Wow, you've gone quite advanced.
Yeah. Botulinum toxin injections are sometimes considered for really stubborn cases, and extracorporeal shockwave therapy, ESWT, is mentioned, though maybe needing more research.
And surgery.
Surgery is really the last resort, reserved for those cases that just haven't responded to a long period of conservative or other non-surgical treatments.
Okay, quite a ladder of options there. So what's the general outlook? If someone gets golfer's elbow, what's the prognosis likely to be?
Generally, it's pretty good, actually,
Yeah.
especially with the right management. Most people, the vast majority, will find their symptoms resolve within about 6 to 12 months, just with that conservative approach we talked about.
That's reassuring.
Yeah, it's often described as self-limiting, meaning it tends to get better on its own eventually, usually within a year for most people.
But not everyone.
Not everyone. Maybe around 5 to 10% might have more persistent trouble and end up needing more involved treatment.
Okay. And prevention is important too, I guess.
Absolutely. If you've had it once, you want to avoid it again. That often means modifying the activities or maybe the technique that caused it in the first place, like getting coaching help for sports to improve form.
Makes sense. Are there any potential downsides or problems down the line? Any complications?
Thankfully, serious complications are pretty rare with golfer's elbow,
Good.
but if it's left untreated or if it becomes really chronic, it can lead to long-term pain, definite limitations in using your arm and hand properly, and that can impact your quality of life.
Yeah, you can imagine.
And it's worth remembering, like with any chronic pain condition, there can be knock-on effects. Some people might develop secondary psychological symptoms, anxiety, maybe depression related to dealing with that persistent pain and limitation.
Yeah, the whole biopsychosocial aspect. Really important to treat it properly then. Okay, we've covered a huge amount. How can we make this stick for revision? Any good memory tips or ways to frame this?
Definitely. Let's try a mnemonic. Think about the M in medial epicondylitis.
Okay.
M for medial means muscles on the inside of the elbow. And these muscles are involved in wrist flexion, bending down, and pronation, palm down. Those are the actions that typically hurt with golfer's elbow.
The medial inside flexion pronation hurts.
Got it. Nice. For risk factors, maybe picture that 40 to 60-year-old golfer gripping a vibrating racket incorrectly. Bit of a caricature, but it hits age, activity vibration, and bad technique.
Huh. Okay, I can picture that. What about an exam-style question?
Yeah, good idea. You might get something like, a 45-year-old keen golfer presents complaining of pain on the inside of their right elbow. It's worse when gripping the club and flexing the wrist. Examination reveals marked tenderness over the medial epicondyle. What's the most likely diagnosis? And your options might be A, lateral epicondylitis, B, medial epicondylitis, C, olecranon bursitis, D, radial tunnel syndrome.
And based on everything we've said, location, aggravating factors, it's got to be B, medial epicondylitis.
Exactly. Remember those key features. Pain on the medial side, worse with wrist flexion and pronation, and maybe those ulnar nerve symptoms in the fourth, fifth fingers.
Brilliant. Those are really helpful pointers. So that really wraps up our deep dive into golfer's elbow. Hopefully that's clarified all the key points you need for revision.
Yeah, hopefully that's distilled it down nicely.
Remember, getting your head around the definition, the causes, the risks, what's actually happening pathologically, how to tell it apart from other elbow problems, the typical features, how it's investigated and managed, the likely outcome, and potential complications. That's the core knowledge.
Absolutely.
For more detailed resources, and especially for practice questions to test yourself, definitely check out PassTheirMSRA.com.
Great resource.
And for loads more free learning materials covering a whole range of topics, head over to FreeMSRA.com.
Yep, another excellent one.
So keep up that focused revision. You'll nail this.